Wonderful. Good morning, everybody. Thank you so much to those of you who have joined online and in person. This is our next installment of the AI on the Ground seminar series. So first, I'd like to start by acknowledging the land we meet on today. Nyadlu Tampindi, Nyadlu Ghana Yatanga in Parendi. Acknowledge the land as being the traditional land of the Ghana peoples. We pay our respects to their elders past, present, and emerging. And I wish to extend my respect to any First Nations folks who are here with us today. So very excited to introduce the presenters today. Mandy Ricard is a nurse practitioner at the Hospital for Sick Kids in Toronto, Canada. Her research interest is focused on hydronephrosis and the use of AI models to predict the severity of hydronephrosis cases. Lauren Erdman is a PhD computer scientist and assistant professor at Cincinnati Children's Hospital in the James M. Anderson Center for Health Systems Excellence. Her research is primarily focused on developing and applying machine learning methods to improve pediatric clinical management. So what these bios don't tell you is that this team of folks in the urology department at Sick Kids Hospital, they were the very first teams at Sick Kids to get the ball rolling on translation of AI systems. They were the very first to sit down with our HREC chair at the time and explain why they needed all the data to do AI work. We were the first to explain why we needed to move down this pathway that had sequential steps toward translation. They've consistently pushed for the next step in evidence generation, and I'm so very pleased to be able to bring you their work today. So with that, I'll turn it over to my friends and AI rock stars, Mandy and Lauren. Thank you.
Thank you, guys. I'm just going to share my screen. So first of all, thanks for inviting us to present. We're super excited to show some of the things we're working on.
I don't know if we can hear down here, Hillary. Sorry, we're just going to get the audio going. All right, can we test?
Yep. Are we good to go?
I think so.
Can you hear me?
Mandy, can you say hi?
Hi, can you guys hear me?
Yes.
Yes, we can.
Perfect.
Okay.
Thank you very much.
Perfect. So thank you guys so much for the opportunity to present some of the interesting work that we've been doing at Sick Kids. And so Lauren and I will talk about a hydronephrosis model, kind of the background of that work and the steps that we've gone through so far. So our objectives tonight, or this morning for you guys, will be to discuss the motivations for developing the Hydronephrosis Severity Index, which is our algorithm that we have, the machine learning model design and training process, the validation of the results across many diverse institutions, and then some key ethical, logistical, and clinical considerations for deployment of a tool like this for clinical practice. And so I just like to share this slide because as part of the 2025 Sick Kids Strategic Plan, personalized medicine is very high on the agenda. And so our institution is very supportive of this type of work, which makes it very easy to kind of go through the process for getting things approved and going through each of the steps that we'll talk about a bit later. So without our very open-minded institution, this work would be a lot harder. And so now I'll give you a little bit of a clinical background, and I'm not sure of the background of the audience here, so I'll try to keep this kind of simple and just a quick overview about why we decided to do this work. And so the clinical focus here is about something called prenatal hydronephrosis. This means that there is an accumulation of urine inside of the kidneys and the ureter. There's several possible causes of hydronephrosis. It occurs in about 1 in 5 pregnancies, and that makes it the most common congenital prenatal anomaly that's detected. This makes up about 30% of our urology clinic volumes, and this is a finding on ultrasound, and it's not a disease or an illness. And so these pictures in this slide are prenatal images. So this is of a fetus before they're born. But it's not uncommon to see a child in our clinic who come with an ultrasound that looks like this. And so what we're seeing here is a kidney with the kidney parenchyma. The black represents urine that's stored inside. And so in this example, this is a baby who's a couple of weeks old with both of the kidneys significantly dilated. And so while approximately 80% of hydronephrosis will be transient and self-limiting, there are different etiologies that definitely require some attention. And so the first example is a ureteropelvic junction obstruction, and that means that there's a narrowing in the ureter here where it joins the kidney, and that results in an obstruction causing urine to accumulate in the kidney alone. You can also have a narrowing of the ureter near the bladder here. That's a ureterovesical junction obstruction or a megaureter. And then the final cause that we typically will focus on here is going to be reflux, which is the backflow of urine from the bladder up to the kidney. The challenge here is that when we get a patient in clinic, there's no way of knowing kind of upfront from a single ultrasound which of these etiologies it's going to be. And considering 80% of hydronephrosis will get better on its own, it's kind of challenging when you're trying to figure out if there's an obstruction requiring surgery versus something we can just monitor conservatively with ultrasound. And so the question here is, why does this matter? If it's the most common congenital anomaly that's detected during pregnancy, does it matter if we are able to intervene or identify the etiology early on? And the answer to that, of course, is yes, because we're all born with a limited amount of renal reserve. And so if you have an obstruction that's gone unaddressed, or you have a child who's having repeated infections, eventually that can have a compromise on their kidney function, which once it's gone, it's irreversible. And so when we think about the goals of hydronephrosis management, so the first one is to prevent deterioration of renal function. The goal of any kidney surgery is not to regain function. Once function is lost, it's lost for good. So we ideally want to be able to intervene early before there's any permanent kidney damage. Another goal is to be able to stratify the patients who will benefit from timely interventions and those who can be monitored just with ultrasound. We want to mitigate the risks of conservative monitoring. So we want to make sure that the child doesn't become symptomatic with infections or stones or kidney pain. A part of all of this is to be able to minimize patient and parent anxiety, to reassure them when necessary, and to be able to identify early if their child would benefit from surgery. And then finally, it's to reduce invasive testing and imaging studies. And there are some current guidelines that help us guide the hydronephrosis management. The issue with these is that they're often a one-size-fits-all approach. And so very frequent monitoring with ultrasound, which is expensive. There's lots of invasive testing that require things like IVs, catheters, and exposure to radiation. And of course, this comes along with pain and discomfort to the child. We also have grading systems that we use to communicate the severity of the hydronephrosis. This is the one that we typically rely on the most, but as you can see, there's room here for a lot of subjectivity when determining which grade of hydronephrosis the child has. And so right now, we make use of the tools that we have to safely monitor these children. And this is kind of the overview of what this looks like now. So you have a child who has prenatally detected hydronephrosis or urinary tract dilatation. These babies are investigated with repeated ultrasounds. Some of them are going to have invasive tests such as the renal scan and the voiding cystourethrogram, which involve catheters, IVs, radiation. And of all of those kids who undergo these tests, less than half actually make it to surgery. And so this leaves us with a crossroads when we're seeing these patients in clinic. Is this a child that needs surgery, or is this a child that could be monitored safely with just ultrasound? And so when we think about ultrasound, some of the limitations of ultrasound, operator dependent, and so it depends on how skilled this person is in doing ultrasounds, especially in children. It doesn't give us information about the function of the kidney or the drainage time. It can't tell us if the child is having reflux. It can give us very limited information about things like scarring or dysplasia. And of course, like I just showed you with this SFU scale, the interpretation can often be subjective. But when we think about the advantages, ultrasound's non-invasive, it's widely tolerated, It's widely available, and there's also no radiation that is incurred by putting kids through ultrasounds. And so a long time ago, about 5 years or so, we sat down and talked about this, and our hypothesis is that there could be information embedded in ultrasound images that can be used to predict important outcomes, like the probability that a child is going to be obstructed, or if there's a very low risk that a child will need surgery, and we can avoid invasive tests and the frequency of ultrasounds. And so we developed a model, which was the phase 1 study that Lauren is going to go into next. And this was the basis that you have information that's visible to a clinician, and then information that's extracted by the model, with the thought that a model can identify patterns beyond human perception, and it can unlock diagnostic signals that are embedded in this image. And so now I'll pass it on to Lauren to kind of talk about some of the machine learning aspects and the research process here.
Thank you, Mandy. I just want to do a mic check. Everyone can hear me? Good. I'll just proceed if, okay, great. As Mandy said, so she mentioned the phase 1, that's the sandbox trial. So this is where they called it a sandbox at our institution, because this is where we collect a lot of imaging and we really explore. So I'm going to tell you about that exploration. And then the second stage we talked about as a silent trial. So once we've kind of nailed down, and I think probably a lot of people in the room are familiar with the silent trial concept because Melissa was a large part of that, is once we've nailed down an algorithm, we want to just put it into play in the background and see how it does if we just were to use it, carrying it forward without any kind of clinical change. And then we're after this, we're going to tell you about a clinical trial we're planning and some challenges and considerations. So we really look forward to even feedback or thoughts or questions. So yeah, so without further ado, I'll tell you about the model. This first model we developed, it was a convolutional neural network, CNN there. We used the hydronephrosis database that Mandy had been very diligently collecting for many years. Everybody in the database was less than 2 years old at baseline. And so it was certainly antenatal hydronephrosis. They had isolated hydronephrosis and or megaureter. They were of all SFU grades. So Mandy showed you that grading system before. Some of them were very mild and some of them were very severe, everywhere on the spectrum. There were no anomalies, so no concurrent urinary tract anomalies. And we included 294 patients for whom we had multiple imaging scans. So we had multiple ultrasounds from each of these patients, and we treated each of those ultrasounds independently in the model. But when we split our 70% training, 30% validation, we split it by patients. So while their individual ultrasound sequences were treated independently, patients were not treated independently in the sense that they were only seen in one phase of the model development. And then our prediction was Hydronephrosis Severity Index score is what we called that prediction. But what it is predicting is if the hydronephrosis is going to resolve on its own. And so this is our publication in Scientific Reports. We also have one from the MICI conference from a few years earlier where we developed our preliminary model. So everything we're going to talk about today is in here except for the clinical trial. All right. So currently we are predicting from postnatal ultrasound using 2 images selected by a clinician or a trained, I will say, research analyst. So in some cases, myself included, after like many hours of training with Mandy and Armando. And so these 2 images are 2 views that are orthogonal to each other of the kidney. We experimented with using one or the other, and there was a slight benefit. So in that first MICI paper, we kind of go through the pros and cons of using one or both of these images. We also looked at different model configurations. So here I'm showing you a Siamese neural network. We also tried ensembling our outcome. We also tried a single neural net. So many different configurations, and this was slightly better. And so what we found, though, with this model was a retrospective AUROC of over 90%. And so this was kind of our first pass, like, wow, we can actually do some prediction here successfully. Then we decided to test beyond sick kids once we had that really nice test set validation. So here I'm just comparing the test sets in the sick kids versus Stanford versus University of Iowa and CHOP data sets. And so first of all, you can see straight away the total number of ultrasounds at our test institutions is much lower. And the unique individuals is much lower. And specifically at UIowa and CHOP, we only had one ultrasound from each individual. The split of male and female is actually quite standard. There's a majority of males, as is seen across all clinics. And so that was as expected. And interestingly, the age distribution was pretty different. So at sick kids, the children were a lot younger. At Stanford, they were all, except for two, between the age of 2 and 5 years old. At UIowa, they were similarly young to sick kids, and at CHOP, they were actually quite widely varied. And so we kind of just let them go for it. Another thing I'm going to mention right now is UIowa. I don't show it here, but they only included high grade patients because they felt that these are the patients that they are most curious how well the model will do on. And so that will show up later in how the model performs, is the different distribution of hydronephrosis severity up front that the model is seeing. So here we're looking at the AUROC on the left. So that's the sensitivity specificity trade-off between at every threshold of our model. And then on the right, we're looking at the AUPRC. So that's the precision and sensitivity or recall trade-off at every threshold of our model. And what we see is the AUROCs are all quite high, except for Stanford. They're 90% or above here. And Stanford actually had the widest confidence intervals too, which was we did find interesting. So more variability in the model performance there. However, when we look at AUPRC, we see that it's a bit lower. There's a bit lower precision at sick kids in Stanford versus University of Iowa and CHOP. And so we found that interesting, since University of Iowa actually has many more severe cases in it, and they're showing higher precision. So they were kind of set up for that in the sense that they had higher surgical cases because they had higher severity of their hydronephrosis up front. CHOP, on the other hand, had a wide distribution of severity, and they still had very high precision. So it was a fascinating finding. The next slide kind of delves into this a bit deeper. So at the we set a threshold of 90% sensitivity in the validation set of our sick kids data. And then we use that threshold in the test set at sick kids, Stanford, University of Iowa, and CHOP. And what we found was we do achieve 90% sensitivity or above at sick kids and University of Iowa, whereas we're slightly below at Stanford and CHOP. So we're above 80%, but not totally there yet. However, it is within the confidence intervals. Interestingly, though, the specificity was lower at University of Iowa. So everyone had very similar specificity, around 70 to 75%. But University of Iowa was a bit less. And so that meant that more of the severe cases are being called as non-resolving hydronephrosis. And so that was an interesting finding to us, kind of expected, but also shows that our model is reflecting that severity grading system as well, in large part, but it's doing it in a way that is objective, in the sense that it's always going to predict the same thing systematically, no matter if the same image is put in. So it has intra-observer, so to speak, no intra-observer variability. So I told you before that we used every single ultrasound in this sequence independently. But we thought since we have those sequential ultrasounds, we should actually consider what a longitudinal model would do and if there is a benefit to it versus just looking at individual ultrasounds. So that's what Stan Hua did in his CPAIM paper. And what we found was really interesting. So our first experiment was just taking the first and the last ultrasound seen. We only had sequential data for Stanford and sick kids, as you saw in the data tables that I showed at the beginning. And what we found was, I mean, two things. One, Stanford had very little data. So when we divided our data into the sequence, we actually got very large confidence intervals, so it was hard to make a conclusion about Stanford. But at sick kids, what we found was there was not a significant difference between prediction from the first or the last ultrasound. So that was kind of exciting for us since that meant that we would be able to predict from the first ultrasound and do as well as we would from the last ultrasound. You see, we get a little bit of a nominal jump there, but it's not statistically significant. Next, we looked at longitudinal modeling, so actually integrating all of those ultrasounds together into creating a prediction. So kind of aggregating the predictive ability of every ultrasound the patient had. Again, Stanford, not really powered to tell us much here, but on this top row in sick kids, we found a minor benefit from a convolutional pooling, or a long short-term memory model. But they were statistically significant, but not clinically significant. So this amounted to a switch of about 2 patients in the change of our model's performance. So here we also felt like that first ultrasound is actually telling us a lot of information about the future in a really powerful way. So this kind of told us there is an opportunity for early decision-making. We're now collecting more data to try to understand if this is possible on a larger scale. So as I alluded to before, once we kind of had a model settled, which was our single time point hydronephrosis severity model, we then wanted to look forward at data and not change anything, not change the model, not change clinical practice, and just have it run and silently to test it against our model. And so that was the silent trial. And we wrote a paper about it here, describing our experience running this silent trial. So for the silent trial, we created an application that was the most bare bones, not even a web app, like it's a Windows app, that you just plug in what's your sagittal frame, what's your transverse frame, check the box if you want to crop the image, or if you have done it already, don't check the box. And then you decide where you want the result to be spit out. And what we had done, what we had a research assistant do was after every time a clinician like Mandy would see the patient, review her clinical advice for it, the research assistant would then take that data, put it into the silent trial model, and then she would record it. And so in this data set of the patients that were seen, there were just over 200 unique individuals with just over 700 ultrasounds. The majority, again, were male, as expected. And again, the majority were under the age of 2. So the silent trial demographics, the silent trial data demographics closely followed our model development demographics as expected. And so the prospective AUROC was over 90%. We were really pleased with actually how this performed. The paper that was shown previously, it showed a little bit of trial and error that we had to come to around the data preparation in our first phase of the silent trial. So we found if the data was saved in a certain format or cropped in a certain way, it was really throwing things off. So once we worked those kinks out and just ran it prospectively, then it performed great. So from here, one thing that we came to understand from that silent trial was how challenging it is for a clinician to interpret just a continuous score. And so here we attempted to create a kind of directive based on our model where we say at the 95% sensitive level and at the 95% specific level in our data, considering where those surgical cases are distributed and where those non-surgical cases are distributed along the continuum, we're going to draw thresholds. And then at those thresholds, we're going to say green light, send the kid home, or just like follow them very loosely, like over a long period of time. Yellow light, you may want to look at prophylaxis. You may want to test them. You may want to heighten your standard of care a little bit more. And then at red light, that is a likely surgical case that you're seeing. Not 100% likely because it's 95% specific. So there are some likely non-surgical cases there. But these kids are likely going to need more interventions and more oversight. So you don't want to let them go like you are your green light kids. And so we did a second like pseudo silent trial with these guys and just followed our same silent trial set 2 years forward, like prospectively for 2 more years. And we found that in our red light category, 71% of them received surgery. So indeed, it was a very high likelihood of surgery in this group. And 24% of them had 24% of them had UTIs, urinary tract infections, which is a big problem when you're super young, as they are. In our yellow light group, there were 34 patients and 9% of them received surgery. So many fewer than red light, but still some, right? So these guys, you do not want to just send home. And 9% of them had UTIs. Last, in our green light group, 1% received surgery and 1% had a UTI. So indeed, they were the lowest severity group. We were happy to see that we were able to predict, really see the future here, but acknowledge that it's not perfect. One of them did require surgery. So it's not a perfect separation, but it's a pretty good indication of who's going to need extra follow-up and who's going to probably be okay. All right, over to you, Mandy. You are muted.
Okay, so now that we've given you guys information about the background work that we've done so far and some of the clinical context, so what are the next steps for us? And so according to that pipeline that Lauren showed, we've gone through phase 1, we've gone through phase 2. So next is going to be phase 3, which is a clinical study. And we've gone back and forth probably for a good year about the best way to design this. And it's still not perfect. And we're going through the ethics board approval process. If we think about the big picture and where this model is going to be beneficial, is it going to be in a tertiary pediatric center where we have experts in pediatric urology who are used to dealing with these kids? Likely not. This is probably not going to help with our decision making that much. But this is going to be more for people in rural areas. This is going to be for pediatricians, obstetricians, to help with risk stratification, to decide which kids actually need to come to a tertiary clinic to be seen by specialists. And so the way we design this model, the primary objective is to determine whether integrating an AI model impacts clinicians' decision-making. And secondary objectives will be to determine the feasibility of integrating a type of model like this into a clinical setting, and to determine the model's impact on management decisions as compared to baseline or pre-artificial intelligence recommendations. And things we need to consider as part of this study, and initially we were back and forth, should this be a pilot? And we're looking at feasibility because these types of tools have not been deployed yet, and there are a lot of other factors aside from how does this perform clinically, such as clinic workflow. Do we have the availability or the available technology and resources to support technology like this? What kind of impact does this have on staff? So the people interacting with the model, how does this impact our clinic workflow? Is it going to take longer to see patients? And then how do parents and families and kids feel about the use of this type of technology in the care of their child, even though our tool is not meant to replace decision-making and more augment decision-making, but it's also important to gain that understanding of their perceptions as well. Another thing to consider is that we're all familiar with the different types of bias that happens in machine learning research, and we know that this creeps in at every stage, and it's part of our responsibility to make sure that we mitigate for this bias as much as possible. And a good example here is a recent paper that we published. And this concept was developed just among conversation with our colleagues who are working on these types of projects. And we found a new type of bias that we called induced belief revision. And what this means is that when you have a clinical person who is involved in every aspect of this research pipeline, so model development, the silent trial, the clinical trial, and you have a person who's making clinical decisions, that's also the same person who is exposed to the input and the model output, that in essence, is it that the clinician's training the model, or is the model training the clinician? And so this is a phenomenon that we noticed, that even before a clinical trial has been done and a model has been deployed, that there is a significant reduction in the amount of invasive testing and a tendency to conservatively monitor kids that is likely based on just exposure to this model. So this is a new type of bias that I think needs to be considered for people who are doing this type of work. A way to mitigate this bias will be to ensure that there are separate individuals who are involved in each aspect of model development. So the testing, the validation, the training, to try to make sure that people are not being influenced by model outputs. Our model seems to perform well, and it seems that the risk here could be fairly low. But if you have a model that hasn't been tested as rigorously and you have clinicians making decisions based on model outputs before it's been thoroughly tested, then there definitely could be a negative impact to patients and families. And the other thing that we need to ensure is fairness. And so I don't need to read the definition. Everybody here knows what fairness in AI is. And this is something that we're also actively working on to make sure that our model is equally as accurate for every type of patient that comes to our clinic to be seen. And so with that, I'll say thank you very much again for the opportunity to present. This is our contact information. We're happy to take any questions.
Amazing. Thank you so much, Mandy and Lauren. It's really cool to see all of this laid out over the entire journey. So thank you so much for taking us through the whole journey, all the way from the first time that you were talking about this, right to where you are now. So thank you so much. I've got a lot of folks online and folks in the audience. We have a mic. All right, we'll open it up for questions. I'm going to look for hands online, and I'm also going to look for comments in the chat. Hi, Ashish, do you want to ask your question, please?
Yep. Thank you, Melissa. Thanks, Mandy and Lauren. Great presentation. I'm not a medical person, but I still could understand a lot of it. So thanks for making it easy. I have two questions. One is really not about the model per se. It's more about how you engage consumers. So if you could just very briefly talk about the initial stages of your communication, your conversations with the consumers on how to get them engaged. What were the discussions? What were the reactions? And how did you convince them to get in?
Do you want to take that, Mandy? So what I would say is, so far the consumers are the urologists of the model,
Okay.
and the patients are along for the ride because they're under the age of 2 for the most part, as you saw, and the families. So far, they've been in the background. So for the clinical trial, they will come up front a little bit more. So I will say our engagement with patients and families has been actually quite minimal, aside from a survey that was done around what are their priorities around care and information that they're getting. In terms of urologists, oh, sorry. In terms of urologists, we've had a lot of engagement. As you saw, multiple institutions really interested to collaborate on this. There's a lot of kind of subjectivity and lack of confidence, not wrongly, when urologists are making a determination looking to the future and grading their ultrasounds. And so that's where we actually got a lot of really positive engagement from the different urologists collaborating, and a lot of really good feedback as well about what is relevant information. Like we showed, if we just give them a score, that's kind of not meaningful, these kinds of things. So that's really where it's been so far. I think as we launch into the clinical trial, we're going to learn a lot, I imagine. Yeah. And Mandy, do you want to add at all to that?
Yeah, I think coming from like a medical background, consumer is kind of a foreign term for me. I would say that our consumers are our patients, and up until this point, with the kind of the background work in the sandbox, if you will, then followed by the silent trial, it's still considered kind of retrospective or behind the scenes. So this work is not influencing patient care. And so we have gotten, as part of like a quality improvement initiative that we have, we do send out parent surveys after clinic visits for some of our specialty clinics, and asking them about machine learning and AI has come up. So without giving them any information at all about the work that's happening, it's just their kind of feeling about this. I would say that, right now it's about 50-50. So I think that gives us even a little bit of information to know that when it comes time for a study, even though the way that we've done the way that we've designed this, it should not really have any impact still on patient care, that it's important to get their buy-in, to let them know that this is happening, that this technology is in use, and then to continuously ask them those questions to see how the parents and the patients feel about their healthcare provider using this technology.
Okay, thank you. And Sanjay, sorry, I'll have just one more quick question. Quickly again, what is the potential of the study in your view and its applicability in other similar areas? Can you just quickly talk about it? Thank you.
Yeah, I think when you have a center with many experts who are competent in taking care of these patients, the usefulness of a model like this or a tool like this may not be obvious. The benefit here is that, at least in Canada, where we have very few pediatric centers that serve a very large population, we see a lot of kids in our clinic that maybe have mild hydronephrosis, that maybe they could have an ultrasound locally in a phone call. Maybe they don't need to be seen at all by a specialist. But the people who are referring them to us and are seeing those patients don't have the expertise to make that decision. So they cast a wide net, and any kidney dilatation is going to get a referral. And why is that? Why is that maybe not necessarily the most efficient? They have to travel a long distance. There's expenses to the families. It congests our clinic, it increases our volumes, and it takes away our attention from the kids who actually might benefit from additional testing or surgeries. And so where we see this going is for a risk stratification tool for people who don't necessarily have that clinical expertise to decide which kids can be safely monitored with ultrasound or who might need a surgical intervention. So that's kind of the end stage of where we see this model going.
Okay, thank you very much.
Thank you so much. I'm going to go to Sanjeev next because he's on clinical service, then Chris, then I'll invite you to comment on Monica's comment in the chat. Sanjeev, go ahead.
Good morning, Mandy and Lauren. I'm really sorry I'm not there. In fact, I only joined in at the very last bit of your conclusion slide. So thank you for this work. And I know that we've had a couple of preliminary conversations going back, Lauren, a while. So I'm really keen to see if we can now make some progress, because I completely endorse your strategy and your approach to what you're doing. And my question to you really was, how long are you guys in town, and whether there was any chance of catching up before you leave?
I was going to say, Sanjeev, don't worry about it. We're not in town. We're broadcasting from Canada and the US.
Amazing.
So...
Okay, so I haven't actually missed this opportunity. Well,
not at all. So book a call with us. Like, let's
excellent,
talk. I think,
excellent.
yes,
I
there's
think
a lot of opportunity.
We're happy
And
to
I
catch
will-
up via Zoom.
Yes, it's great
Lovely.
to see
Will
you.
do. Will do. So I'm sorry, I'm going to zoom back in because my next patient's asleep, but I was really keen to find out whether there was any chance catching. So I'll liaise with Melissa. And yeah,
Perfect.
Melissa,
Great to
bring him
see
down.
you.
Bring him down here. Show them what the
I'm
best
doing my
company in the
best.
world looks like. Bye.
Thanks, Sanjeev. Chris?
Yeah, thank you, Lauren and Mandy. My question, apologies if I did miss this, was to do with the actual ultrasound devices and the transducers design. Just across the 4 institutions, did you specify as part of the research that everyone had to use a certain specification model, all that kind of stuff?
That's a great question. Actually, we get this a lot, especially for people with technical expertise about ultrasound itself. When we developed the model, so I'll just talk about the development data set and then I'll talk about the rest of the test first. Or second. We had a free-for-all in our own clinic. There were 6 ultrasound devices that were used, and we didn't put any specifications on them. We just said, we'll just download the PAC system ultrasounds that were collected for hydronephrosis surveillance, period. Standard of care, no guidelines around that. And we found that there was a slight difference in performance. None of them dipped below our performance we showed significantly, statistically significantly, but there was some nominal dips in our oldest machines because when you just look at the images, they're just a bit blurrier. So as the image gets sharper, as expected, you get a bit better of a prediction, which was in a way a nice sanity check. Then going to our test institutions, again, total free-for-all. We not only, as I said, choose the patients you'd actually want to use this model on. So University of Iowa took the most severe patients. We also said, just bring us again, like the images that were collected through standard of care. No kind of guideline around that collection, no transducer guideline, anything like that. So this is truly free for all. They collected what machine it was done on, like what machine was used for the collection of the ultrasound, and we found no significant difference in terms of that. Where we were powered to test it, which in this case was Stanford, they had a more diverse machines, but enough volume from each machine to test against each other. But again, we did not see a difference in the machines, and we also saw the validation out externally to sick kids. So yeah, so far it looks like it is pretty robust across institutions. As I said, we are collecting more data from more institutions, including those institutions, just more patients and more images to kind of more robustly test this and get enough power to really see is there some kind of difference. But it looks like the images that are collected in standard of care are similar enough. Even the sequence itself is quite similar across institutions, that it is sufficient for the model. That's where, sorry, I know I'm taking a lot of time with this answer, but that's where Mandy's comment about the community using this algorithm, it becomes a little troublesome because when you get to ultrasound sequences collected in the community, they're not as great. And that's just like a complaint we hear across the board, across many countries, many physicians. And so that's where we're trying to actually create a guidance for collecting those ultrasounds so they're a bit more standardized, and then they can also be used in the model. So that's going to be a next step in terms of actually like reducing the community demand for quaternary and tertiary care centers for their expertise.
Yeah, and Lauren, so it won't just be the devices, the arrays and configuration. So being really specific would be really useful to see. Yeah.
Absolutely.
I think another important point, sorry, we just lost power here. So now everything's reset. I'm hotspotting from my phone. I didn't hear if you talked about POCUS, but that's the next direction that we're going. So we have a lot of point of care ultrasound that we do in our clinics. And so ideally, especially in remote, northern underserviced communities, we're working with the Indigenous Council to try to improve screening for care for congenital kidney abnormalities here. And the reality is that, especially in some of these remote places, you're going to have a clinical provider who has a point of care ultrasound. So that's the next thing that we're looking at, is to try to use point of care ultrasound images obtained by clinicians versus the fancy radiology ultrasound machines obtained by technologists to see how our model performs there as kind of another next step.
Thank you both. So I'm going to read out Monica's comment in the chat, which is related to the consumer. How do you envision to communicate your prediction in terms of user interface and visualization, integrated into hospital system, considering the workflow of the AHN, visual tools, or just numbers and so on? And the question is about trust and explainability of AI. And you should know Lana's here too, so she's checking your answer.
I think you can answer this one, Lauren.
Okay, great. Okay, Mandy, you may have to jump in because I might be saying something pretty controversial. Right now, we are thinking of like the stoplight kind of system in terms of how it's communicated to the consumers. So how it would be communicated and explained to the patients. We'd basically say, your child's ultrasound was fed into the machine. This is based on previous patients. This is how severe our model says it is. And based on that, that's how we would proceed with your clinical surveillance. Of course, this will also come with the clinician's own judgment. And so that's actually within the trial, that if the clinician disagrees with what the machine says and says, you know what, I don't actually think this is not severe, or I think that this is not so severe, even though the algorithm says it is, then that also would be communicated to the patient. So pretty simple. We're not, because it is a CNN, we're not going to lean a lot on any kind of feature explanations, anything like that. It is going to be kind of hand wavy, unfortunately, at this point in the communication. Any thoughts on that, Mandy? Or anything to add?
No, I think initially with like the like phase 1 and even the silent trial, we were getting the grad cams, and maybe you can talk about some of the newer the newer issues that have come up with respect to applying a heat map over the image. The intention was good in that, as a clinician who looked at that model, showing you the areas of the image that was using to make the prediction helped with that type of explainability. But now, from my understanding, Lauren has more of a technology understanding of this. There are some drawbacks to using grad cams and heat maps to identify these areas of interest, but initially that's what we were using. And so now it will be more of a threshold, the red light, green light, yellow light, and then the discussion with the family.
Yeah, exactly. And just to elaborate on what Mandy was talking about, we've kind of pulled away from using the grad cam because we don't want to, I should say, like, the grad cam focuses nicely on the kidney, and it focuses nicely. There's a way to kind of explain away the prediction, no matter what part of the kidney it's focusing on. It could be focusing on the pyramids, the parenchyma, the collecting region, like that dilatation, and it does it all. It really, it focuses on all of that. And that's where we actually wanted to keep the clinician having their own judgment and their own interpretation of the image, and then synthesize the model's result and understand it as essentially an averaging of the past of what's been seen in the hospital. And so that's kind of our reasoning about that. That's not to say it won't change. As I said, we really learn every time we kind of take this out and try it again and expose other people to it. So we're certainly not set in stone on that.
I think it's a really great point, and especially in line with the conversations that are evolving around explainability and potential influences. So really appreciate the thoughtfulness that you've both given. Min has a question. I'm hoping you can unmute. Yeah, okay, perfect.
Hi, thank you very much for the talk. I really enjoy it, and I'm glad that you taking it to the next level of clinical trial. So speaking about that, I'm like to ask a question about what does it take to convince you and I assume there's a committee to approve the move ahead with the clinical trial. I've seen the results that you have in terms of the AOC area under the curve for the ROC and the precision recall curve. It's very high at 90% accuracy or whatever, or maybe lower for precision recall. And you also mentioned it's not perfect, but at the same time, I also see kind of like very large standard deviation or error bar that you have for each of those. So obviously you have thought a lot about this, and it's good enough. That's why you move ahead to the next phase. But for my own understanding, I don't, say if I want to decide what problem I should be working on. I'm not in clinical or medical study at all. So I want to kind of understand what is the right problem. And for me, is that a very hard problem? I should not even consider it because it's just too difficult that would make to the clinical impact. If you can shed some light on, the near misses, or what are the critical things that would convince yourself and other people that it is something impactful and it worth going through clinical trial. It would be wonderful. Thank you.
So I think that given the multi-center validation, the results are very promising across the board. When we're talking about a pediatric institution with images obtained by radiology, there's going to be a lot of similarities, kind of regardless of where that happens. The way that we've proposed this clinical trial, and this is still going through an ethics review here, and I'm sure there's going to be many iterations. This is just our initial protocol. The way that we've designed it is not necessarily like, how does this compare to a clinical expert's decision making? We know that it was trained by experts, so it should perform fairly well and very similar to a clinical expert. But it's mostly how, if people who don't have this expertise interact with this model, how will that influence their decision making in 3 ways? Does this child need follow-up? Does this child need an invasive test, or does this child require surgery? And so having people with less experience in our clinic, that would mean that that's trainees, so residents, fellows, medical students, clinical nurse specialists, who will interact with the model after seeing a patient to see how that influences their clinical decision-making, because at the end of the day, they're still going to review with the clinical expert who's in clinic with them. And it's still, at this point, not necessarily influencing the patient care, because the expert or the clinician who's the most responsible person for that patient is ultimately going to decide what the plan of care is going to be. But it's for people who have less experience in managing these kids, because ultimately, this is where we see this model being most affected or most effective, is people who don't necessarily have that expertise. And until we can be assured, I suppose, like, or what's the balance here? The balance is we see every single child in Ontario who has hydronephrosis, knowing that we will miss 0 patients, versus can we apply this risk stratification tool to people who don't have this expertise to help them decide who should be seen by experts? That's the balance that we need to sort out. And maybe more testing is going to be needed. Maybe we need a trial that happens in a remote community where we still have the oversight and we're reviewing all of these ultrasounds to say that in the hands of a person who's not as experienced, this model is safe. Like, maybe that's a study that needs to be considered before we say that, like, wide and free, this is the model that can be deployed and safely used no matter where you are. I think other testing is going to be needed. And because this process is still relatively new, despite that it's sick kids, and now I know, because I'm a part of the RAB, there are lots of other groups that are heading in this direction of model deployment. All of these questions that are coming up are still new to us as an RAB panel, but also as a clinician who's using this technology and who's pushing this technology. So I think a lot of these questions we can't answer, and I think we're going to have to learn these things together. And so I think at the end of all of this, it needs to be safe patient care. And as a group, we need to make sure that we agree that however this next phase is approved and organized is going to be safe. And so if that means before a clinical trial, we do a pilot, or it's another silent trial that we have to do, we're not really sure yet, but this is still very new, I think, in terms of like research ethics and the technology that's available at sick kids, who I think are very advanced and forward facing. And it's another, I think, strength of our institution is that we recognize that, and it's not a free-for-all, and it's a very responsible assessment of all of these tools to decide what can be safely deployed before it impacts patient care.
Yeah. And I'll just add to that, Mandy, to just in like my terms, it's that the sensitivity is above 90%. Like, the sensitivity remains high. It's even actually higher than 90% when we thresholded it when we projected it into the prospective silent trial. And so as long as it's there, then everything is gravy. to be Canadian about it. So any reduction in follow-up in those low risk cases, then that's a benefit. The alternative is kind of what Mandy described, but within just the clinic, it's like everybody's kind of going through the same process versus there's going to be people who are put into that really high risk group and then people who are put into medium and low risk. And they won't not see a clinician anymore. So even that green group, they'll still have a number to the clinic. Maybe they'll still have at least a follow-up to verify that they're proceeding safely to resolution independent of any kind of intervention, just to verify the model's results. So that's kind of the expectation too, is that we're not just kind of, sometimes when I've presented this at urology conferences, surgeons are like, oh my gosh, are you trying to tell me this model is going to tell me who to operate on? And it's like, absolutely not. You saw that, that specificity, like you should not operate on everyone who says, who the model says is high risk, but those people who the model says are low risk, they actually are going to get to go home and not come in as much. And so that's where like striking that balance between the very high intervention cases and the very low intervention. And then I just wanted to answer your second question about how to choose what to work on. I think the people really matter. As Mandy showed you, we had to go back and forth on this, like trial and error, learn new things, talk a lot about what we're experiencing, both on the modeling side and on the clinical side, and on the like, this doesn't really make sense to me for both of us side. We brought a lot of different people into the group. And so finding a team, like finding a clinical collaborating team is extremely important. And so part of that is they'll share their data with you so you can even see if there's a there very early on. Because I think with, this is also helping to answer Mehar's question. It wasn't a lot of data. And we started with even less data, but even with a small amount of data, we found, wow, there's a really strong signal there. Like this is definitely, the model is definitely seeing something that seems real. And we just kept trying to break it and validate and refit and test. And we kept finding like, yeah, it keeps working. So there's really something there. If you don't have a team that's going to give you the data and let you kind of run with it and see, and also accept like Mandy and Armando and the group and I, like we've tried a lot of different things. So they're not all getting really nice publications. So some things are just going to fail. And the idea is like, you want to fast fail, or you want to be able to shelve something until there's like foundation models when you can then say, oh, you know what, maybe we'll be a little more powered to work on this. And then you can even take it off the shelf. But I think you really need people to play ball with you on the clinical side to also help create like, what are the questions, get the data, and create something meaningful that clinicians will actually take on. And Mehar, I hope that helped answer your question as well.
Yeah, thank you very much. Yeah, thank you.
Yeah.
Amazing. Thank you so much. And that also gave me a great segue to plug. Lauren has a really nice paper on clinical collab sheets, helping guide some of these conversations with clinicians to get the most out of those collaborations. I love this paper. It's such a good paper. So thank you for giving me the opportunity to plug that as well. And I just want to say thank you both so much. I mean, you've set such an incredible standard that I think, you know, we all want to follow. This is the vision of what I think, you know, the highest standard of translation is. So really, really appreciate you both sharing this with us today. Thank you to your team that's on the call, and thank you to everybody who is here today. I'm going to wrap it up today. Thank you so much for joining us, and we'll look forward to seeing you at the next AI on the Ground. Have a great day or night, everybody.